Hmm.
Dr. Manoj?
Can I go start, sir?
Yeah, please.
Okay, sure. Good evening, ladies and gentlemen. Welcome to 12th episode of Secrets of Neurology. It is a knowledge feast for all neurologists across the country. And we are extremely proud of our program directors who have been running this at the end of every Friday. Dr. Sudhir Shah and Dr. Lakshmi Narasimhan. A warm welcome to both of you, sir. And also warm welcome to the faculty of Stanley Medical College, Chennai. It's my privilege to introduce the first program director, none other than Dr. Sudhir Shah. We know him very well, professor and head of the department at prestigious NHL MMC and SVPI MSR Ahmedabad. And Dr. Shah is also director of neuroscience at prestigious Sterling Hospital Ahmedabad. Many awards and accolades to Sir's credit, author of 6 books, and because of his contribution to society and science, Government of India also conferred the prestigious Padam Shri. He is also recipient of prestigious Dr. B.C. Roy Award and also recipient of UNO Award, just to mention a few. Dr. Shah's interest is into stroke, neurodegenerative disease, and epilepsy. Thank you, sir, for making the last Friday of every month so enriching and so interesting for all of us. Our second program director is equally eminent, Professor Dr. Lakshmi Narasimhan. Sir was the student of Madras Medical College, where now he is HOD and director. Many awards and accolades to Dr. Lakshmi Narasimhan's credit as well. PAL2C Advisor from AN, A.V. Baker's Award, Best Paper Award at AN, and his contribution to society, science, and students of neurology in particular is extremely high. Sir, a warm welcome to both of you, and may I request both of you to take it forward from here.
Thank you. Thank you, Dr. Manoj, for those kind and nice words. I welcome all of you on behalf of Secrets of Neurology, Pulse of Wisdom. As you would remember that in the last year, in the month of July, last Friday, we started with the first episode. And today, in month of June 2021, we have completed 12 most interesting, profoundly knowledgeable 12 episodes. And I am very satisfied and gratified to say that hundreds and hundreds of neurologists and students and faculty have attended this all programs with lot of zeal, enthusiasm, and excitement. In fact, it is learning for all of us, not let alone the students, but it is also learning for the faculty and those budding neurologists. So the cases that have been displayed across were master cases, and the way they were dissected were also equally interesting and upgrading kind of our knowledge. So it is a most gratifying job, and we hope to continue the Secrets of Neurology series even further. And so next year on July last last Friday, we'll have the celebration, virtual celebration with the new year. Thank you, INTAS, Global Cell Division, Mr. Arun Chadda, Dr. Manoj Kumar, Dr. Heli, and the whole team for continuous support, logistic support for these webinars. At this juncture, I shall be most ungrateful if I don't mention the profound role played by my colleague, a very humble man, a man with tremendous knowledge and huge impact in the field of neurology as well as medicine. That is Dr. Lakshmi Narasimhan, who has been the backbone of this web series. And we must thank him enough for his contribution and continuous efforts to make this a most successful webinar series. So I really thank you, Dr. Lakshmi Narasimhan, for your all efforts and inputs. Now today, at the completion of first year, there's a 12th episode we have, and we have none other than a wonderful team from Government Stanley Medical College from Madras. May I have the first slide, please? And it is headed by Dr. Mukundan, as you know, and the case will be presented today by Dr. Jay Kishan, who is a medical student, and he, I think, is a senior resident, and he will be presenting the case scenario. Next slide, please. Mr. Satish Kumar is the assistant professor. Hello. Dr. Satish Kumar is the assistant professor. He is in the same department, Government Stanley Medical College, and he is an MBBS, MD, DM, as well as he has a lot of awards and achievements, including Association of Physicians of India PG Teaching Program Gold Medal, uh, 10 con quiz second place, 10 con best platform presentation. He has to his credit to talk on emergency neurology in Pondicherry. His areas of interest are stroke and rehabilitation, and he has some publications of note, that is e-journal published under the case series of Japanese encephalitis, osmotic deviation syndrome paper, arginase deficiency, RANCON 2018, and a contributed chapter on immunology and cognition reviews of neurology. So that is our assistant professor from this. Dr. P.R. Somni, she's an associate professor, very well known, and she's also MBBS, MD, DM. She had a Dr. Sivarajan ECG gold medal in 2007 while pursuing general medicine, first prize in MG medal exam. Then she also has TN Dr. MGR Medical University gold medal, and her areas of interest are divination, neuroimmunology, neuromuscular disorders. And she has publication, original articles, and case reports in national index journals. Next, please. Another associate professor from the same institute is Dr. Vivek Saravanan. I think he is going to dissect the case further, and he is again MD, DM from Madras Medical College, and he has been affiliated to government Thanjavur Medical College till 2010, and then 2019 he worked as assistant professor of pediatric neurology childhood, and from 2019 onwards he has been working as associate professor of neurology at Government Stanley Medical College, Chennai. He has areas of interest pediatric neurology, electrophysiology, and his publications are on metabolic seizures, etc. etc. And study on 2, 3, 4, 6 cranial nerves as you can read. Next slide, please. And I have a great pleasure in introducing my fond friend, Professor Dr. K. Mukundan. He is Professor and Head Department of Neurology, Government Stanley Medical College, Chennai. Apart from having a lot of accolades and memberships and publications, we all know him as a very thorough man, a gentleman, kind personality, and a man of worth. He he's on the governing body member. He's a national API. He's been very active in Association of Physicians of India, I've been told. And he's a governing body member. He's a faculty council member of ICP. He is a past secretary of American College of Physicians India chapter, member advisory board of JAPI. There is a general joint secretary Indian College of Physicians, and executive committee member at Tamil Nadu Association of Neurologists. His areas of interest are epilepsy, stroke, neuromuscular disorders. He has been confirmed with FICP in 2016, FSCP in USA, and FRCP Glasgow in 2017, FRCP done in 2019, FRCP had in 2020. So a lot of accolades which are very apt to him. He has received also Dr. V.R. Joshi Outstanding Referee JAPI Award at Epicon 2016. He has edited monograph on epilepsy and immune-mediated neurological disorders, and he has published numerous articles in national and international journals. So uh, I think he will be the man who will give final verdict and comments on the case. So with this introduction and with a lot of thanks to all of you, my lovely dear audience, that because of you, we have been able to continue this with a lot of zeal. And thanks for your continuous presence and support. So with this, I hand over to Professor Mukundan to start the proceeding for today's case. Thank you.
Sir, good evening. Am I audible?
Yes.
Yes, sir.
Sir, first of all, I thank Professor Sudhir Shah. He is the professor and head Nadiba Hargovan Das Lakshmi Chand Municipal Medical College, Ahmedabad, and also he is the head of the department in Sardar Vallabhbhai Patel Institute and Research Center, Ahmedabad. And Professor Lakshmi Narasimhan, Director, Madras Institute of Neurology, for giving us the opportunity to discuss this case in the Neurology Secret Forum. So with this, we will start the proceedings. First, I request Dr. Jayakrishnan, our exam-going PG, to present the case history.
Respected teachers, seniors, and my friends, very good evening to all.
I'm Dr. Jayakrishnan, neurology resident from Government Stanley Medical College, Chennai. I will be presenting the case, history and examination. A 20-year-old young lady, graduate, born of non-consanguineous marriage, presented with the chief complaints of decreased hearing in both ears since past 7 years, unsteadiness of stance and gait with clumsiness of both hands since past 3 years, slurring of speech since past 2 years, weakness of all 4 limbs since past 2 years. Patient developed decreased hearing in both ears since past 7 years, which was insidious in onset and gradually progressive in nature. It was also associated with ringing sensation in both ears. But she doesn't have any history of dizziness, ear discharge, or ear pain, and there was no history of any exposure to ototoxic drugs. Patient also developed unsteadiness of stance and gait since past 3 years, which was insidious in onset and gradually progressive in nature. She had difficulty in negotiating narrow pathways initially and was associated with swaying to both sides while walking. It was associated with clumsiness of both hands also. There is no history of any worsening of unsteadiness in dark or cotton wool sensation in both feet while walking, and she doesn't have any history of tremors. Patient also developed slurring of speech since past 2 years, which was insidious in onset and progressive. Speech is slurred with undue pauses in between. She developed weakness of all 4 limbs since past 2 years, which was insidious in onset and gradually progressive. Initially, she had difficulty in gripping chappals in both feet, and gradually she developed buckling of knees, followed by difficulty in getting up from the squatting posture, and then developed difficulty in holding objects in both hands and difficulty in raising the upper limbs above the shoulder. Weakness was associated with flailness of all 4 limbs. There is no history of difficulty in turning over in the bed or difficulty in raising neck from the bed. She doesn't have any history suggestive of extraocular, facial, or bulbar muscle weakness. There is no history of thinning or twitching of muscles, diurnal variation of weakness, muscle cramps, or myotonia. There is no history of any memory disturbances, seizures, headache, or altered sensorium. There is no history suggestive of any other cranial nerve involvement, sensory disturbances, bowel or bladder involvement, or any other involuntary movements. She doesn't have any history of night blindness, eye or skin lesions. There is no history of any breathlessness at rest or exertion, recurrent respiratory tract infections, chronic diarrhea or weight loss, and there is no history suggestive of diabetes mellitus or hypothyroidism. And she doesn't have any history of exposure to toxins or drugs, and there is no history suggestive of malignancies or connective tissue disorders. Past history: she is born of non-consanguineous marriage. Birth and development are normal. There is no history of any significant medical illness in the past. And there is no history of similar illness in the past in the family in past 3 generations. Patient was evaluated by neurologists outside 3 years back and was treated as post-infectious cerebellitis with intravenous methylprednisolone 1 gram daily for 5 days, followed by oral steroids for a few months. She was treated again with IV and oral steroids at another hospital 1 year later, but she did not show any improvement with this steroid therapy. Coming to the summary of history: 20-year-old young female presenting with insidious onset, gradually progressive neurological illness of 7 years duration in the form of hard of hearing associated with tinnitus, unsteadiness of stance and gaits with swaying to either sides while walking, not worsening in dark, not associated with vertigo, and slurring of speech with undue pauses in between, symmetrical distal followed by proximal flail weakness of all 4 limbs without any extraocular, facial, bulbar muscle weakness with normal higher mental, sensory, and autonomic functions. There is no history suggestive of night blindness, telangiectasias, cardiac diseases, recurrent respiratory tract infections, thyroid disorders, diabetes, malabsorption, malignancies, connective tissue disorders, drug or toxin exposures, and with no history of similar illness in the family. On general examination, she is conscious and oriented, moderately built and nourished. Height neck ratio is 12.5. Blood pressure is 120/70 millimeter mercury, measured in the right upper limb in supine posture. Pulse rate is 86 per minute regular. There is no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. There is no cataract or KF ring. There is no goiter, no telangiectasias or tendon xanthomas, no skin hyperpigmentation or ichthyosis. Peripheral nerve examination was normal. There is no skeletal abnormalities like kyphoscoliosis or pes cavus. Examination of central nervous system. Higher mental function evaluation was normal with MMSE score of 30 out of 30. Cranial nerve examination. Examination of olfactory nerve was normal. Optic nerve examination. Visual acuity is 6/36 bilateral, which improved to 6/24 with pinhole. Color vision and visual fields are normal. Fundus examination showed temporal pallor on both eyes, but there was no evidence of any pigmentary retinopathy. Examination of third, fourth, and sixth cranial nerves. Extraocular movements are full bilateral without any ptosis. There was bilateral horizontal gaze above nystagmus. Examination of the fifth and seventh cranial nerves were normal. On examination of vestibulocochlear nerve, Rennie's test was positive and there was no lateralization on Weber. Absolute bone conduction test was diminished on both ears, suggesting sensory neural hearing loss pattern on both ears. Examination of the lower cranial nerves was normal. On examination of the motor system, patient was having wasting of intrinsic muscles of both hands and feet with bilateral wrist and foot drop. Tone was diminished in all four limbs. She was having a distal predominant weakness of all four limbs with a power of 3/5 over both upper and lower limbs proximally and 1/5 over both upper and lower limbs distally. Superficial reflexes are normal. Plantar is mute bilaterally. Dependent reflexes are absent in all four limbs. Examination of sensory system revealed graded sensory loss of touch, pain, and temperature over both lower limbs up to mid-thigh and both upper limbs up to wrist joint. Vibration sense was diminished up to knee bilaterally. Joint position sensation was lost in toes of both feet. Examination of cerebellum. Patient was having titubation, bilateral horizontal gaze above nystagmus, scanning dysarthria, truncal ataxia. We couldn't do the finger nose test and heel shin test because of severe weakness, and stance and gait also could not be assessed. Cranium and spine examination was normal. So summary after history and examination. 20-year-old lady presenting with insidious onset, gradually progressive neurological illness of 7 years duration in the form of hard of hearing associated with tinnitus, unsteadiness of stance and gaze with swaying to either sides while walking, slurring of speech with undue pauses in between, and symmetrical distal followed by proximal flail type of weakness of all four limbs. Examination revealed features of early optic atrophy, bilateral sensory neural hearing loss, titubation, bilateral horizontal gaze above nystagmus, scanning dysarthria, truncal ataxia, symmetrical distal more than proximal weakness of all four limbs with hypotonia and areflexia, and glow and stalking type of sensory loss. I'll show the video of the patient.
அக்கா பேரு அக்கா பேரு
சிந்து
என்ன பண்ற நீ?
பிகாம் முடிச்சிருக்கேன்.
எங்க?
என்ன காலேஜ்?
எந்த காலேஜ்?
டாக்டர் எம்ஜிஆர் ஜானகி காலேஜ்.
எத்தனாவது இயர்?
என்ன
இயர்
ஃபைனல் பண்ணிட்டேன்.
அம்மா பேர் என்ன?
மகாலட்சுமி
அப்பா
ஜானசேகரன்.
வயசு எவ்வளவு?
என்னோட 20.
చక్రవర్తి రాజగోపాలాచారి. చక్రవర్తి రాజగోపాలాచారి.
చక్రవర్తి రాజగోపాలాచారి. ఇతను చక్రవర్తి రాజగోపాలాచారి.
Sir, shall I ask Dr. Satish Kumar to localize?
Please go ahead, sir. Yeah.
Yes. May I request Dr. Satish Kumar to localize the both symptomatology and signs?
Good evening, everyone. I'm Dr. Satish Kumar, Assistant Professor in Government Stanley Medical College. I would like to thank Professor Sudhir Shah, Professor Lakshmi Narasimhan sir, and my chief, Professor Mukundan sir, for giving me the opportunity to present in this forum. And I also thank the organizers for giving me this opportunity. As our resident presented, a 20-year-old young female presented with a chronic progressive neurological illness of 7 years of duration. To begin with, she had hard of hearing for 7 years. So whenever we approach a symptom of hard of hearing, we have to differentiate it basically from a conductive or a sensory neural. Usually in conductive type of conductive type of hearing loss, patient may have associated ear discharge or ear blockade. They can have oral fullness, and usually a sensory neural hearing loss patient will have a tinnitus associated, as in our case. And moreover, in conductive hearing loss, they may hear clearly, but in a lower volume. But in sensory neural hearing loss patients will hear sound, but that will be distorted. That too, in a noisy environment, the sensory neural hearing loss patients will not be able to hear clearly. So next we have to assess whether it is unilateral or bilateral, and it is progressive or very sudden in onset. And moreover, we have to assess whether the hard of hearing is complete or partial. As I said, sensory neural hearing loss will always be associated with the tinnitus association rather than with the conductive hearing loss. And regarding the examination in sensory neural hearing loss, Rini will be positive, and Weber will not be any lateralization will not be there in Weber, unlike conductive hearing loss. An absolute bone conduction test, it will be less than the examiner and it will be also diminished. So in this case, where all the possible sites of localization could be cochlea or a cochlear nerve. And regarding the cochlea and cochlear nerve, they can produce commonly associated with the tinnitus and a sensory neural hearing loss. Whereas in brainstem and auditory cortex, there is a binaural representation in the tracks. So brainstem and auditory cortex, the central pathways are less likely to produce a sensory neural hearing loss in day-to-day clinical practice, unless it is a destructive bilateral brainstem lesions. The next symptom, she presented with unsteadiness of walking, unsteadiness while standing, and also she had a clumsiness in hands with the dysarthria. So the unsteadiness suggests an ataxia. Now we have to differentiate whether it is a vestibular or a sensory or a cerebellar. In this case, there is no associated prominent vertigo. So vestibular usually will be associated with a prominent vertigo symptoms. And in sensory ataxia, the patient do not have any worsening of unsteadiness in darkness. So as per the history more suggests a cerebellar ataxia. And regarding the examination, the patient had gait, but from the history, the patient had a gait and stance ataxia, which can be localized to the vermis or its connections. And regarding the clumsiness in hands, which means an appendicular ataxia, that can be localized to the cerebellar hemispheres. And regarding the scanning dysarthria, we usually localize typically to the paravermis region, particularly in the left side. And regarding the horizontal gaze evoked nystagmus, it occurs mainly due to the leaky neural integrator because of the flocculus lesion. And all these features, if we combine, almost all structures of the cerebellum or its connections are involved. So I'm naming it as a pancerebellar ataxia or its connections. The other symptom, the third symptom, what she said was weakness of all four limbs, which started insidiously and progressed slowly. And the flailness was very strongly associated with the weakness, as the patient had a foot drop and a wrist drop. And also there was a thinning. So all these suggest an element pattern of weakness. And that weakness is also a symmetric weakness and areflexic, in which distal is more than proximal. Regarding the element pattern of weakness, anterior horn cell usually produce asymmetric pattern of weakness. There can be a differential weakness, and there can also be associated twitchings, which is not in our case. And regarding the muscle, it will be bilateral and symmetric, and moreover, it is proximal. Here it is distal more than proximal. And also, this patient did not have any fatigability or a diurnal variation. So NMJ can be ruled out in this case. And regarding the root, the patient has more of distal weakness, so less likely to be root lesions. So I would like to localize it to a peripheral nerve. And in combination with though the patient didn't report any sensory symptoms, she had sensory findings in the pattern of a graded sensory loss involving the pain and temperature up to mid-thigh, which suggests that small fibers are involved. And also she had a joint position vibration loss in the lower limbs, which suggests a large fibers involvement. So putting it together, the motor and sensory findings, it is in a stocking and glove pattern neuropathy, where up to mid-thigh, when the graded sensory loss has reached, the patient also had symptoms in hands. So this particularly fits in a stocking and glove pattern neuropathy. So combining both motor and sensory, the peripheral nerve could be the best localizing site. And regarding the temporal pallor, the patient had temporal pallor with the decreased visual acuity, which suggests an early optic atrophy. So to summarize, the following structures are involved in this patient. It's either it starts with a bilateral cochlea or a cochlear nerve, a pancerebellum and or its connections, and the peripheral nerves are involved, that too in a length dependent fashion, and bilateral optic nerves. So I would like to hand over to, thank you for giving me this opportunity, and I would like to hand over to Dr. Saumani for further discussion. Differential. Yeah. Yes, ma'am.
Good evening to all. I sincerely thank the organizers of this meeting, Professor Sudhisha sir, as well as my teacher, Professor Dr. Lakshmi Narasimhan sir, and my HOD, Professor Dr. Mugundan sir, for giving me this opportunity. So having localized the lesion, next we go on to the differential diagnosis based on the core clinical features of this particular patient. So the cardinal clinical features of this case, so we have a young lady, a 20-year-old female born out of non-consanguineous parentage, presenting with insidious onset, gradually progressive neurological illness of 7 years duration, having the following 4 core features. Severe sensory neural hearing loss to start with, which happened 7 years back, followed by cerebellar ataxia, which started 3 years back, then severe sensory motor peripheral neuropathy, and then early optic atrophy, which was detected on examination. And she had no family history of similar illness, which is a very important point. So as with any case in neurology, we first, even though the history is typically a long one, lasting for the past 7 years, I still would like to consider the reversible treatable causes first. I would like to rule out the reversible or treatable causes of chronic ataxias before going on to the inherited ataxias. And this patient didn't have any family history of similar illness also. So all the more, we'll have to first rule out the reversible treatable causes, namely hypothyroidism. But the patient significantly did not have any history of thyroid disease according to the history. Vitamin deficiencies, namely B1, B6, B12 deficiencies, which can present with cerebellar ataxia. But there were no significant clinical examination signs which were evident on general examination to show such vitamin deficiency. And drugs and toxins, there was no history of exposure to drugs and toxins in this particular patient, but still we'll have to keep in mind exposure to anti-epileptic drugs and heavy metals and several other drugs and toxins can cause chronic ataxias. Chronic infections, namely neurosyphilis, HIV infections can cause such a picture of a subacute to chronic ataxia. So I'll keep that also in mind and investigate in that direction to rule out the chronic infections. And then the most important one, gluten sensitivity. Gluten sensitivity can present with many various neurological manifestations, most important of which will be ataxia, followed by peripheral neuropathy. And since this patient had two of them, that is, she had both cerebellar ataxia, pan-cerebellar ataxia, as well as severe peripheral neuropathy. I will have the possibility of gluten sensitivity while evaluating the patient. But of course, she didn't have any history of malabsorption, no history of any chronic diarrhea, and there was no history of any intolerance to gluten-rich food. And the next possibility among the autoimmune causes, we have anti-GAD antibody syndrome, which can present with chronic cerebellar ataxia. So the last one, superficial siderosis, can also present with subacute to chronic ataxias. So these are some of the reversible treatable causes, which I will rule out before going on to the other genetic causes. Of course, among the genetic ataxias, we have some ataxias which are partially reversible, like ataxia with vitamin E deficiency, A-beta lipoproteinemia or hypo-beta lipoproteinemia, cerebrotendinous xanthomatosis, Refsum disease, ataxia with coenzyme Q10 deficiency. So all these, by doing some dietary alterations, by giving some supplements, we can at least partially reverse or halt the progression of the genetic ataxias. So I'll keep in mind these partially reversible causes of genetic ataxias before going on to the untreatable ones. The inherited ataxia syndromes, we very well know this patient has no family history of similar illness, but still we see many sporadic cerebellar ataxia patients presenting with presenting with inherited ataxia syndromes and which are genetically proven also later on with no family history. So among the inherited ataxia syndromes, I like to think about two broad classifications based upon the age of onset of illness in this particular patient. First group will be autosomal recessive ataxia syndromes. The second group will be the mitochondrial ataxia syndromes. So going on first to the autosomal recessive ataxia syndromes, we know we have a long list. This is only a limited list. We have still more, more than 20 ataxias which are inherited in an autosomal recessive manner. The most common autosomal recessive ataxia which can present as early onset cerebellar ataxia is Friedreich's ataxia, which is known to everyone. And this has its onset usually in the second decade. And the first initial presenting symptom will be ataxia or gait instability. And this gait instability can be contributed by both the cerebellar involvement as well as the sensory involvement. We know the cerebellar tracts, the dorsal and ventral spinocerebellar tracts are being involved, as well as the dorsal root ganglion is being involved here. So the ataxia can be contributed by both. So in our patient, significantly, this patient had sensory neural hearing loss as the first symptom from the age of 13 years. Ataxia came later on. And we know Friedreich's ataxia patients, majority of the patients, the hearing difficulty is confirmed only with the audiogram or other evoked potential studies. Many patients don't present with deafness as a symptom. So that I'll keep in mind. And then this other features of Friedreich's ataxia, namely areflexia with extensor plantar response, the associated diabetes, cardiac abnormalities, the skeletal deformities, we know Pescavus scoliosis, and an association with sensory axonal neuropathy. I like to emphasize this. This patient has both Glovenstocking sensory loss as well as weakness, significant weakness, distal more than proximal weakness, which is very significant. Proximal part being 3 and the distal part being 1. Such a severe peripheral nerve involvement we don't usually see in Friedreich's ataxia. So usually they'll have minimal sensory symptoms, and NC nerve conduction study usually confirms the sensory axonal neuropathy. The next close differential in the autosomal recessive ataxia group will be ataxia with vitamin E deficiency, which is exactly similar to the Friedreich's ataxia phenotype. And the age of onset is 4 to 20 years. These age of onset, many times it's very variable. And progressive trunk limb ataxia, dysarthria, suggesting cerebellar involvement, Babinski sign, abolished DTR, scoliosis, Pescavus, retinopathy, pigmentary retinopathy, which was not present in fundus examination of our patient. Scoliosis, Pescavus also was not present. Sensory neuropathy, again, it is not a sensory motor one, it is a sensory neuropathy. And associated dystonia, head titubation, and cardiomyopathy are frequently seen in AVD. Then this A beta lipoproteinemia, which is closely related, which again causes vitamin E deficiency secondarily, and that also compounds the picture. So A beta lipoproteinemia, it's a multi-system disorder and usually has its onset very early in life, maybe in the first year of life. Main manifestations are chronic diarrhea, failure to thrive, and our patient didn't have all this. Neurological features usually appear in the after the first decade, in the second decade of life, with absent DTR, sensory neuropathy, weakness, and ataxia. Again, sensory neuropathy I'd like to underline here. And investigations will reveal acanthocytosis, and ophthalmic examination, this atypical pigmentary retinopathy, and the spinocerebellar degeneration will be the underlying main clinical feature. The third one, Refsum disease. It's a paroxysomal disorder, as we know, and characterized by pigmentary retinopathy, ataxia. Here we have a mixed motor sensory but demyelinating type of neuropathy. So in this patient, while doing evaluation, I will look for it in the nerve conduction study, and elevated CSF protein, which again should be looked up. This occurs before 20 years of age and associated with night blindness secondary to the pigmentary retinopathy, followed by progressive visual field constriction, optic atrophy, cataracts, vitreous opacities, and nystagmus. Anosmia, cochlear deafness, ichthyosis, and cardiac abnormalities are other associated features. CTX or cerebrotendinous xanthomatosis, presence with juvenile cataracts, chronic diarrhea, and tendon xanthomas. All these were not present in this patient based on the history as well as the examination. These are just mentioned to hint on what to consider when encountered with a patient with early onset cerebellar ataxia. So progressive neurological deterioration characterized by cognitive decline, psychiatric manifestations, ataxia, progressive spastic paraplegia, dysphagia, and less frequently seizures and peripheral neuropathy. Elevated serum cholesterol will be the biochemical hallmark. Ataxia with coenzyme Q10 deficiency characterized with progressive ataxia, dysarthria, cerebellar atrophy on imaging, reduced muscle CoQ10, blood CoQ10 may be normal, and characterized by multiple neurological symptoms and signs. Ataxia telangiectasia, the onset itself, it will be before 3 years of age. Telangiectasia will be the hallmark, and this was not present in our patient. Anyhow, this also is one of the early onset cerebellar ataxia, and usually these patients become bedridden by 10 years of age, and they'll have complicating chronic sinopulmonary infections, and there will be an increased susceptibility to cancer. So ATLD, again, a very rare one, clinical condition. but wherein there's be a slowly progressive ataxia, onset can be variable, but here there is no facial or ocular telangiectasias, and there's no increased risk for infections or malignancies. Ataxia with oculomotor apraxia 1, 2, 3, and even 4 we have. Patient did not have oculomotor apraxia, first of all, on clinical examination, but still again, as told earlier, this comes under one of the early onset cerebellar ataxia, and just I'm mentioning about this. And maybe while investigating the patient, we'll have to take into account this hypoalbuminemia, hypercholesterolemia, and elevated CK to conclude. And peripheral neuropathy signs will be very predominant in this patient, along with the oculomotor signs and cerebellar ataxia. AOA2 again, global progressive ataxia, characterized with pancerebellar ataxia, dysarthria, as well as peripheral neuropathy, motor and sensory neuropathy. We'll have to note this, with oculomotor apraxia being present in only less than 50%, whereas in AOA1 it will be present in 80 to 90%. And oculomotor, other oculomotor signs can be present. Cognitive function is usually preserved. So AOA3 and AOA4 are less well described. And going on to spinocerebellar ataxia with axonal neuropathy, scan 1. Again, age of onset less than 14 years. Core features will be cerebellar ataxia with peripheral neuropathy characterized by distal atrophy associated with pes cavus and sensory findings in the lower limbs. Epilepsy may occur. So nerve conduction study here will disclose motor as well as sensory involvement of a axonal type. ARSAX, again, it's been described in initially in a selected group of people in Canada. Now it has been described in several other populations also. Here, characteristically, patient will have spasticity. It's autosomal recessive spastic ataxia of Charlevoix sanguinae. So there will be a delay in acquiring independent walk, gait instability, a peculiar gait which is characteristic of ARSAX. And along with ataxia, patient will have spastic paraplegia. And now our patient doesn't have this. Lower limb peripheral neuropathy may evolve later. When the peripheral neuropathy evolves, the spasticity pyramidal signs can be masked, but still the Babinski sign is said to be present. And they have a very peculiar fundus picture wherein there is a hypermyelination of the nerve fibers radiating from the optic disc. Marinesco-Sjogren syndrome, it's a rare multisystem disorder with congenital or early onset cataracts, developmental delay, and cerebellar ataxia. Again, this doesn't fit into our patient's clinical features. So this is an algorithm as to how to approach a patient with hereditary cerebellar ataxia with onset less than 25 years. But this is basically based on the investigations. So now at present, since we are in the clinical picture, this may not be useful. So it's based on MRI features and the blood investigations and nerve conduction studies. I just wanted to share it because it will be very useful for the postgraduates while evaluating the patient along with the investigations. The next set, that is the inherited ataxia syndrome, which is associated with mitochondrial disorders. Here we have, we know mitochondrial disorders, there are a lot. The ones which are commonly associated with cerebellar ataxia are MERF, NARP, MELAS, KSS, Kearns-Sayre syndrome. MELAS we know, mitochondrial encephalopathy with lactic acidosis and stroke-like episodes. NARP is neuropathy, ataxia retinitis pigmentosa. MERF is myoclonic epilepsy with rag-bred fibers. And the other ones which are very rare, namely mitochondrial spinocerebellar ataxia with epilepsy. Primary CoQ10 again is also classified under mitochondrial disorders. Then the Paul-G mutation. So mitochondrial disorders can give rise to pure cerebellar, spinocerebellar, or pure sensory ataxia also, because we know it's a multi-system disorder. Even extra neurological involvements also will be associated sometimes. So cerebellar ataxia is a frequently reported symptom in mitochondrial DNA defects. And as I told earlier, MELAS, MERF, NARP, and the Paul-G mutation. One is MIRAS and the other one is SANDO. MIRAS is mitochondrial recessive ataxia syndrome. SANDO is sensory ataxia, neuropathy, dysarthria, and ophthalmoplegia. So these two are classified under Paul-G or POLG related ataxia neuropathy spectrum. So what we'll have to note in mitochondrial ataxias is genetic testing is not always positive. So the specific mitochondrial DNA mutation may not be detectable in blood sometimes. So muscle biopsy will be a useful investigation in the diagnostic workup of suspected cases. So mitochondrial disease, we know it's likely to be a cause of ataxia in up to 1/4 of patients presenting with ataxia. 23% in one study was due to mitochondrial disease. When we just study patients with idiopathic progressive cerebellar ataxia, 1/4 will be by mitochondrial disease. And when additional features like deafness, retinitis pigmentosa, ophthalmoplegia, diabetes, myoclonus, neuropathy, myopathy, spastic paraparesis, when all these are present, it's more likely to be a mitochondrial disease, and we'll have to look for it. Pure ataxia with nothing else is less likely to be due to mitochondrial disease. So cerebellar ataxia plus syndromes we say, then we'll have to consider mitochondrial. And again, last line, normal muscle histology, even muscle biopsy can be negative. So if it is normal muscle histology and histochemistry, still we are not excluding mitochondrial disease totally. We'll have to follow up the patient. The others are very rare ones. I just hint on three diseases alone among others. One is CAPOS, which is cerebellar ataxia, areflexia, Pescavus optic atrophy, sensory neural hearing loss, which is recently been related to ATP1A3 gene. We know ATP1A3 gene has also been described in rapid onset dystonia Parkinsonism, as well as alternating hemiplegia of childhood. So this ATP1A3 gene has wide variety of neurological disorders related to it. So this CAPOS was initially an acronym which was given before the genetic study was done on these patients. And here, this also doesn't fit into our patient because the onset is usually very early childhood, mean age being 2.5 years. And usually patients have an episodic ataxia and episodic encephalopathy. Whenever the patient has fever, patient has aggravation of the neurological symptoms. PHARC, polyneuropathy, hearing loss, ataxia, RP, and cataract localized to ABHD12 gene. So this disrupts the endocannabinoid system, and it's again a neurodegenerative disease caused, which is characterized by the 4 features which I told earlier. So since the clinical features reasonably fits into our patient, I just wanted to mention this also in the differential. But then again, the patients will have demyelinating sensory motor polyneuropathy in PHARC. And ACPHD is an ataxia, combined cerebellar and peripheral ataxia with hearing loss, and diabetes mellitus, and another autosomal recessive disorder caused by loss of function mutations in DNAG C3 gene. All these are rare ones, so I kept it in the last. So I don't know whether I have to mention this, but then still, sometimes autosomal dominant cerebellar ataxia can also have a wide age of presentation. It can be a bit early, sometimes very late also. Usually we think of autosomal dominant spinocerebellar ataxias when we see ataxia in patients above 40 years. But still, there are rare reports of early onset of autosomal dominant cerebellar ataxia. Now, I have discussed the entire case. I have discussed the differential diagnosis based on cerebellar ataxia as the main feature. So ataxia plus syndromes I had discussed so far. So should I also consider inherited neuropathy syndromes, taking into account neuropathy as the core feature? But seems to be less likely because the patient does not, even though she has severe neuropathy, the ataxia is also equally predominant in this patient. So that's why Refsum disease alone was considered among the inherited neuropathies. Inherited optic neuropathy syndrome or optic atrophy syndromes also seems to be less likely because patient does not had not presented with optic neuropathy. It was found only on examination. So she didn't come with history of any visual disturbances. So finally, I'd like to end by saying that I will first rule out all the potentially treatable reversible cause of ataxia with appropriate investigations, and then consider the following genetic ataxias. So first possibility will be ataxias associated with mitochondrial disorders, taking into account the sensory neural hearing loss, which appeared first, followed by ataxia, and then severe sensory motor peripheral neuropathy, severe enough to cause weakness of the grade of 1/5 distally and 3/5 proximally, and early optic atrophy also. So that will be the first possibility. Second, Refsum disease. even though pigmentary retinopathy was not there, she had sensorineural hearing loss along with severe peripheral neuropathy and ataxia. So Refsum disease forms a second one, differential. The third will be still being the common early onset ataxia. I'll just try, also keep Friedreich's ataxia and its close mimicker ataxia with vitamin E deficiency being a treatable one, at least partially treatable one. I'll also keep that as the fourth possibility. Thank you very much.
Dr. Vivek Saravanan, Associate Professor of Neurology, to give his learning points in this case.
Good evening to all. First of all, I would like to thank the organizers, and I would like to thank my respected teacher, Professor Lakshmi Narasimhan sir, and Professor Sudhir Shah sir, and my HOD, Professor Mukundan sir, for giving me this opportunity. So, as already elaborately discussed by our colleague, Dr. Saumini madam, I would like to add a few more points, learning points in this forum. As discussed earlier, this patient is a young female with a history of deafness and peripheral neuropathy, along with cerebellar signs, and as well as early optic atrophy. So our focus is more towards mitochondrial disorders as well as autosomal recessive ataxias. So while considering the classification or approach to autosomal recessive ataxias, recently I came across one interesting way of classification of autosomal recessive ataxias. Previously, they used to classify by means of, by the basis of age of onset, as well as etiological factors like inherited, metabolic, all those things. But this one I found somewhat interesting and somewhat related to this patient. This autosomal recessive ataxias divided into three categories based on cerebellar ataxia with predominant sensory neuropathy. So in that comes the Friedreich's ataxia and Sandoz, Golgi mutation causing sensory ataxic neuropathy, dysarthria, and ophthalmoplegia. As I said, this is based on the sensory neuropathy features, but as we insist, there are other core features for every subtype of this sensory autosomal recessive ataxic neuropathy, sensory ataxias, like Friedreich's ataxia will be having its other core features like scoliosis and all other things. And second thing, cerebellar ataxia with sensory motor axonal neuropathy, like in case of ataxia telangiectasia, ataxia with oculomotor apraxia, and cerebrotendinous xanthomatosis. And third type, cerebellar ataxia without any obvious sensory neuropathy, like in this case of autosomal recessive cerebellar ataxias, cerebellar ataxia type 1 with SIGN1 mutation, autosomal recessive cerebellar ataxia with ADCK3 mutation, and Niemann-Pick disease type C. So in our patient, the patient is having more of sensory motor changes, sensory motor axonal neuropathy. Why they say is because the patient is having sensory as well as predominant distal motor weakness as well as wasting in this patient. So now coming to the other narrower differential diagnosis, that is mitochondrial disorders. So as you know, all know, mitochondrial DNA mutations can also cause ataxia. And these are group of disorders associated with abnormalities of mitochondrial energy metabolism, mainly the oxidative phosphorylation, OXPHOS. So this respiratory chain depends on two genetic systems, nuclear and mitochondrial genomes. So any defect in both this nuclear as well as mitochondrial genomes may present with mitochondrial phenotypical genetic disorders. So one peculiar thing about this mitochondrial genetic mutations, DNA mutations, is these disorders can mimic autosomal dominant, recessive, or X-linked transmission due to their heteroplasmy and threshold effects. So as already mentioned by Madam, the diseases are Chiari syndrome, MERF, NARP, MELAS, Leak syndrome, all come under this mitochondrial disorders. And one important thing is, because of the tissue-specific mitochondrial defects, that is heteroplasmy, muscle biopsy should be performed because mitochondrial defects are more likely to be defected in the non-dividing cells such as muscles. So in addition to the genomic studies, it's better to do a muscle biopsy instead of wholly depending upon this genomic studies. It will be better to do a muscle biopsy in case of mitochondrial disorders. So nowadays, the recent focus is more towards some of the genes, especially this gene, the POLG gene. So the POLG gene is nothing but a nuclear gene coding for polymerase gamma, which is involved in the maintenance of mitochondrial DNA. Nowadays, many people used to prefer doing this test in many recessive ataxic disorders for POLG, because in future what they say is this is going to outnumber even Frederiksen gene in the frequency they predict. The POLG phenotype is very varied and includes Alpers syndrome and chronic progressive external ophthalmoplegia, neuropathy, epilepsy, and some movement disorder, including myoclonus, Parkinsonism, and cerebral ataxia. So its ataxia neuropathy phenotype seems to be associated with a specific recessive mutation in this gene. So and as already discussed, acronyms referring to this clinical constellation are mitochondrial recessive ataxia syndrome, MIRAS, and sensory ataxia neuropathy, dysarthria, ophthalmoplegia, that is Sandoz syndrome. So approximately 2/3 of patients with the POLG ataxia develop seizures, and almost 1/2 develop ophthalmoplegia, while clinical myopathy is very rare. So as I have mentioned about this biopsy, in patients with myopathy with mitochondrial disorders, the muscle biopsy is going to demonstrate increased SDS expression indicating mitochondrial proliferation. So while going through the phenotype of our patient, I came across this interesting entity, that is infantile onset spinocerebellar ataxia. So this one is an early onset hepatocerebral presentation, similar to Alpers syndrome, has also been associated in 2 siblings with recessive PEO1 progressive external ophthalmoplegia 1 mutation. So why I am mentioning this in this thing is because phenotypically also it has features fitting into our patient, and also it come across it's due to a mitochondrial DNA depletion in liver. So the usual onset is between 9 to 18 months of age, usually in children, and the children develop acutely or subacutely ataxia, hypotonia, athetosis, and areflexia, and by teenage years they lose independent ambulation. So as I mentioned, many features are progressive external ophthalmoplegia, optic atrophy, sensory neural hearing loss, cognitive impairment, sensory neuropathy, and autonomic nervous system dysfunction may occur in this case. So other thing I want to mention, so we have talked about this autosomal recessive ataxias and mitochondrial disorders. So we have to also think of X-linked recessive ataxias, but one thing is many of these X-linked recessive ataxias are of late age onset, and this one is very interesting, this fragile X tremor ataxia syndrome. And this one presents with action tremors, behavioral changes, autonomic dysfunction, and usually having a family history of learning disability. So coming to the generalized or usually the usual genetic approach to hereditary ataxia, the first approach to the diagnosis of hereditary ataxia is to test for repeat expansion, because so as we know, we can go for targeted sequencing, or otherwise we can, after that we can go for whole genome sequencing or whole exon sequencing. So why we go for preferably targeted genome sequencing? Because many of the autonomic dominant ataxias as well as autosomal recessive ataxias are mainly due to this repeat expansion, trinucleated repeat expansion. So we can easily detect early this repeat expansion before going for whole genome sequencing. We can detect it by targeted sequencing, especially this autosomal dominant ataxias with repeat expansion like SCA1, SCA2, SCA3, and SCA6, and autosomal recessive disorders with CAG repeat nucleated expansions like Friedreich's ataxias, X-linked ataxias, fragile X tremor ataxia syndrome. So as I said, after excluding the repeat related ataxias with this targeted genome sequencing, then we can go for whole exome sequencing, and they are useful in determining sequence alteration. And there are also limitations for this whole exome sequencing in ataxia evaluation. They are not sensitive for large chromosomal deletions or duplications, and also they are not sensitive for mitochondrial genome mutations, and also they are sometimes not sensitive for repeat expansions in the non-coding regions. So a genetic diagnostic test for ataxia should be coupled with the clinical presentation for appropriate genetic testings. So, and few words regarding this immune-mediated ataxias. In contrary to the usual belief, this one, most of the immune-mediated ataxias are of late onset. And regarding this gluten sensitivity, many of the patients will have the skin involvement called dermatitis herpetiformis. And nowadays, there is a debate going on whether is there an entity of gluten sensitivities or is there or not, because in many patients, anti-gliadin antibodies on evaluation of the ataxic patients, they find out these anti-gliadin antibodies are being found out in higher levels in even in normal individuals, as well as in many subtypes of spinocerebellar ataxias, like in spinocerebellar ataxia type 20. So nowadays they are going for more specific antibodies for this gluten sensitivity, like tissue transglutaminase 6. And another point regarding this anti-GAD antibodies, usually they may present with peripheral neuropathy, and sometimes they may present with a variable presentation like rigidity. And as Madam has mentioned about this SRIAT, previously called as Hashimoto's encephalopathy, now they are using this term SRIAT. But the thing is, it's different because of this subacute onset, and also it is having the features like psychosis, cognitive impairment, and more than 50% of the patients will present with seizures and involuntary movements, especially myoclonus. And one important point for this Whipple's disease, one clue for this Whipple disease will be of oculomastigatory myarrhythmia. So to conclude, when going through family history of ataxias, check also for other movement disorders, for example, spinocerebellar ataxia type 3, because many patients in the previous generations can present only with the Parkinsonism rather than ataxia. And in case of mitochondrial disorders, many generations will present just with early onset diabetes mellitus and deafness, and Friedreich's ataxia may present in earlier generations with only learning disability and premature ovarian failure. Thank you. Thank you all.
So we will go for investigation, sir. I request Dr. Jay Krishnan to go for investigations.
Great going, great going.
I will summarize the investigations now. Patients' routine blood evaluations were normal. Sugars, renal and liver parameters were normal. Fasting lipid profile was normal. Serum TSH level was normal. HIV and VDR came negative. ANA and ENA profile came negative. CSF analysis showed normal sugar protein levels, and it was SLR. Cytology was normal. Chest X-ray was normal. There was no evidence of any cardiomegaly. ECG and echocardiogram was normal. There was no evidence of any cardiac conduction defects on ECG, and there was no evidence for any cardiomyopathy. USG abdomen was normal. There was no organomegaly. Serum CPK levels was normal. Serum lactate and pyruvate levels were normal, and the lactate pyruvate ratio was normal. Serum AFP levels was normal. Vitamin B12 levels was normal. Anti-TTG antibody came negative. We have done nerve conduction study of all 4 limbs, and it showed features suggestive of severe sensory motor axonal polyneuropathy. Pure tone audiometry showed features of severe bilateral sensory neural hearing loss. VEP showed prolonged P100 latency on both eyes, with P100 latency on the right side was 148 millisecond and left side was 152 millisecond. MRI showed diffuse cerebellar atrophy. This is the nerve conduction study report of ulnar motor study on both sides. It shows showing axonal changes on both sides. All other nerves were not stimulatable. Severe axonal sensory motor polyneuropathy. Here the VEP showing a prolonged P100 latency on both sides. MRI brain of showing T1, T2 and FLAIR images showing cerebellar atrophy, diffuse cerebellar atrophy. Then we have done the nerve biopsy and muscle biopsy. Nerve biopsy was done from the sural nerve. It showed features of acute and chronic axonal neuropathy. Muscle biopsy showed features of neurogenic atrophy without any evidence of RAG drug fibers. This is the nerve and muscle biopsy report, which was done at NIMHANS, Bangalore. It showed features of neurogenic atrophy and without any features of RAG drug fibers and acute and chronic axonal neuropathy. So after the muscle, from the biopsy, we proceeded with the genetic study. Frataxin gene mutation came negative. Whole mitochondrial gene sequencing also came normal. The whole exome sequencing showed phospholipase D3 mutation suggestive of spinocerebellar ataxia 46. So this is the genetics study report of whole mitochondrial genome sequencing done from MedGenome. It showed a normal report without no abnormality was detected in. This is whole exome sequencing, which showed a phospholipase D3 mutation suggesting spinocerebellar ataxia 46.
I request Dr. Srinivasan. Here, he is a neurogeneticist from MedGenome, Bangalore. He will highlight the genetic studies done in this case.
Good evening, everyone. Are you able to hear?
Yes.
Yes.
Thanks, Dr. Mukundan. So this case came to MedGenome for both clinical exome sequencing and whole mitochondrial genome sequencing. The clinical exome, the whole mitochondrial genome sequencing, we did not find any variants of interest. But the clinical exome sequencing, we were able to identify a PDL a variation in the PDL3 gene. The PDL3 gene, if you look at the report, what we have identified is that there was a variation in the 77th position of a T to C nucleotide, which is located in the exon 4 of the PLD3 gene. This had a heterozygous zygosity, and then according to OMIM phenotype, this was associated with spinocerebellar ataxia 46. So this follows a autosomal dominant inheritance. And if you look at the characteristic of this variation, this was a heterozygous missense variation. So a variation in the 77 position from T to C led to amino acid substitution of threonine instead of isoleucine. And it was in the 26th codon of that exon 4 region of the gene. And there were no earlier reports of the same variation in any of the databases, which included OMIM, which is online Mendelian inheritance in men, in human genetic mutation databases, ClinVar, SwissVar, and also our Indian database. If you look at the frequency of this particular variation, this was very rare because the minor allele frequency was 0.001%. And in silico presentation, you know, when we actually simulate this variant in silico, we found that this might be a benign variant, but still, you know, we didn't have any functional studies to confirm the same. So ideally, this was reported as a variant of unknown significance for a simple reason that, you know, there were no earlier literature related to this variant, one. Number two, we also didn't have parental, exploring this variation in the parents to decipher the segregation pattern of this particular variant. So what we suggested was to explore testing the same variation in the parents, considering that this is an autosomal dominant inheritance disease. And another interesting thing was that a missense variation was observed in the same gene in some other position, which was in the lysine 2 proline in the 308 amino acid position, which was again associated with SCA46. So the ideal approach should be that, you know, we recommended to go with the classification of this variant to a likely pathogenic, depending on testing for the same variant in the parents.
Thank you, sir. Zoom.
No.
Sir, after investigation, I request Dr. Savamini to say a few words.
The slide.
Adilla.
The slide. Neurology secret.
Zoom.
Okay.
Zoom.
So after investigations, we have reasonably ruled out all the reversible, treatable causes of ataxia, which I discussed earlier. And the genetic diagnosis was a surprise to us because the age of onset of the patient, the motor neuropathy, which was very evident and predominant in the patient along with the sensory neuropathy. And the sensory neural hearing loss. So going into literature of SCA46, SCA46, we could find that there were some features which were not fitting into the phenotypical presentation of this patient. But there were many other features which were fitting also. So we are planning to do the parental study also, so that as the dentist had earlier told, so that may throw more light into the significance of this PLD3 mutation, which we have noted ascribed to SCA46. And so we will get back with the parental genetic report. The concluding remarks, our professor and HOD will now enlighten. Thank you.
JK, slide. Slide share report, yeah. The clinical manifestation in our patient are the age of onset, before puberty, no family history. The predominant features in this case are pancerebellar ataxia and severe sensory motor axonal polyneuropathy, and also sensory neural hearing loss and early optic atrophy. We encountered a novel mutation, that is PLD3. We reviewed the literature regarding this. In 1995, Van Dijk et al. Has published a paper on new variant of sensory ataxic neuropathy with autosomal dominant inheritance in Brain, the Journal of Neurology, in which a large Dutch kindred with 4 siblings and their father had adult onset sensory ataxic neuropathy with cerebellar signs. He has described sensory ataxia in 2 generations, of course, with late onset of symptoms after the age of 40 and slow progression. Clinical nerve cutting study and nerve biopsy revealed a sensory axonal neuropathy and also eye movement disturbances, probably of cerebellar involvement. As the disease is inherited from the affected father to his sons and daughters, this was the first description of a probably of autosomal dominant form of late onset hereditary sensory neuropathy with prominent sensory ataxia and cerebellar signs. Genetic study was not done at that time because the year is 1995. Then in 2017, Esther Nibbling et al. She has published an article, that is exome sequencing and network analysis identifies shared mechanisms underlying spinocerebellar ataxia. In this, she found 3 types of genes, which includes a follow-up of the family reported by the Van Dijk et al. In 1995, which showed heterogeneous missense mutation in the PLD3 gene. So the re-evaluation of the extended family members confirmed a variable combination of sensory neuropathy and cerebellar ataxia in the affected family members. But in a small subset of patients, cerebellar phenotype was more prominent than sensory neuropathy. Oculomotor examination was almost normal in all patients, but the average age was relatively late, ranging from 35 years. This is the journal. So the novel SCA genes were FAT2, FAT1 and PLD3 and KF26B. In our case, we encountered a novel mutation of PLD3, that is phospholipase a family member 3. The clinical features were age of onset starting from 35 years, slow progression. There was a mixed both sensory and cerebral ataxia. Gait disturbance was more than limb ataxias. Variable dysarthria absent to severe, then nystagmus. MRI showing mild cerebral atrophy. Journal of Neurology 2019 summarizes the major clinical characteristic of novel SEA genes described since 2015, in which the phospholipase D3, which was linked to SEA46. The predominant feature is cerebral ataxia with polyneuropathy, like our case. The pathogenic mechanism is haploinsufficiency of phospholipase D activity. The Journal of Neurology 2019, which gives the SEA subtypes with associated clinical signs and features, predominantly with cerebral ataxia. The first and foremost is peripheral neuropathy, in which SEA46 is there. The other the clinical features are mentioned. Few words about phospholipase D3. It's a protein encoded by the PLD3 gene. Is highly expressed in the brain and mainly localized to the endoplasmic reticulum and lysosome. Play a role in regulating lysosomal systems, myogenesis, neurogenesis, and amyloid precursor protein processing. In 2017, the PLD3 gene was identified as one of the novel genes linked to spinocerebellar ataxia 46. Spinocerebellar ataxia 46 is a rare type of SEA. The inheritance is autosomal dominant, caused by, all of us know, mutations in the phospholipase D3 gene. Only one large Dutch family has been reported. The core clinical features are adult onset, starting from 35 years, slow progression, like our case, cerebral ataxia with peripheral neuropathy. In cerebral ataxia, gait and limb ataxia, dysarthria and nystagmus with mild cerebral atrophy on MRI. Peripheral neuropathy, patient will have impaired distal sensation. Sensory axonal neuropathy by nerve contact study and nerve biopsy. Ocular manifestations, nystagmus, and so on. The clinical manifestation in our patient, the age of onset is little bit early, no family history. The core features are pancerebral ataxia and sensory axonal neuropathy, severe sensory neural hearing loss, and early optic atrophy. The SEA46 has pancerebellar ataxia and severe sensory axonal neuropathy in the literature, but due to wide phenotypic variation, I think we will have more articles regarding deafness and sensory neural hearing loss. As of now, the diagnosis is sporadic spinocerebellar ataxia, probably of SEA46. The patient was admitted just before the second wave of COVID-19. We worked up. Then I must thank Dr. Srinivasan Medjino from Bangalore for the genetic report, and he has advised parental genetic reporting. We are planning to do in the next week, because my well-wisher Lakshmi Narasimhan told it's an ongoing program, the neurology secret. I will come back with the final diagnosis after the parental genetic report. Again, I thank Professor Sudhir Shah, Professor and Head of the Department, Sardar Vallabhbhai Patel Institute of Medical Science and Research Center, Ahmedabad, my senior colleague, Dr. Lakshmi Narasimhan, Director, Madras Institute of Neurology, for giving us the opportunity. I thank my teammates, Dr. Jay Krishnan, the presenter, my colleague, Dr. Satish Kumar, for discussing the localization, and Dr. Saumini for discussing the differential diagnosis and the provisional diagnosis, and my colleague Dr. Vivek Saravanan for the important learning points. And also, I thank my colleagues, Dr. Malcolm Jairaj, Dr. Sakti Velaidam, and all my residents for their valuable help in working with the patient. My special thanks to Dr. Srinivasan, MedGenome Lab, Bangalore, for his valuable help in genetic testing. Thank you, sir.
Most welcome.
Yes, sir.
Thank you.
Most welcome.
Thank you for a wonderful presentation, Dr. Mukundan.
Thank you.
And it again proves that based on age, we should never come to a conclusion whether it is dominant or recessive. Once again, reiterating the fact that age can be misleading in deciding the inheritance. And secondly, thanks for digging the genetics and bringing out a wonderful diagnosis, which will really enrich the students of neurology. And Dr. Saumini and Dr. Vivek Saravanan have made me feel proud about that. They're all from our institute alumni. I am proud that they're doing so well. And Dr. Mukundan also is from my alumni, sir. His alma mater is Madras Institute of Neurology, and they're doing so well in Stanley. I'm proud of all of them. And the young presenter, my congratulations to him. He did very well. And I really enjoyed the sequence and of events and wonderful discussion and all the lovely points which they highlighted. And my sincere thanks to my mentor, my guide, Professor Sudhir Shah, who is the backbone of this neurological secrets. And the first year completion on a wonderful note on the excellent presentation by Mukundan will be the feather in the crown for this entire program. We'll be starting the new year on the 30th of July, last Friday, with Professor Sangeeta Rawat from Mumbai. And she will be discussing a case, and will be traveling from south to the west to the capital of Maharashtra, where she will be taking over the case next week. Meanwhile, my sincere thanks to Dr. Manoj Kumar, Kelly, and Mr. Arun Chadda for their valuable inputs. And as a Dr. Srinivas, the genetist from MedGenome, thanks for his participation in our program, and being the presence of a genetist is a value addition for us in this clinical discussion. Thank you so much. We learned so many things from you. Over to Professor Sudhir Shah for the final comments and conclusion.
Thank you, Dr. Lakshmi. And I must congratulate Professor Mukundan and the whole team for wonderfully discussing, dissecting, and enlightening from the whole case. Now, in neurology, as we know, it is the approach and how you dissect the case that is most important. That is the beauty of neurology, and no other branch has such a wonderful way of understanding a case. And I think they have done real great justice to the case and dissected. It was for the benefit of all of us, particularly the exam going neuro resident, because we know that exams are around. Now, I must first also thank all the audience that are present till now. I must thank once again Professor Mukundan and the team, Professor Lakshmi, and of course the team in TAS. On a closing note, please don't forget that COVID is still around. We have lost one of the greatest all-time great personality 2 days back, Professor Ashok Pangaria, and we would like to pay homage to this great man. And we we pray God for the peace of the noble soul. And I want all of you to take all possible precautions, because from different analysis, it is evident that most likely we'll be hitting the third wave in the month of September with a peak, and maybe we have to take all the possible measures. Don't let the guard down. I'm sure you all have taken vaccines, take all other precautions, and look after yourself and your loved ones. Thank you very much, and best wishes to all of you.
Sir, and I also joined Professor Sudhir Shah in passing my condolences to the greatest neurologist of the country, Professor Ashok Pangaria. May his soul rest in peace. Which he, in fact, we had his Shraddhanjali a few days back on behalf of the Indian Academy of Neurology, and the neurology secrets, the series also, the team also takes in conveying our condolences to the great professor of neurology, Professor Pangaria, who has created a generation of neurologists who fall back, and he may rest, his soul may rest in peace. Thank you. And with these words, and I think we meet on July 30th, 8 p.m. on Friday. Thank you. Over to Arun Chandra.
Thank you, sir. And today it's a great day that we are at the end of the 12th session of Secrets of Neurology, the longest web series. The entire 12 sessions turned out to be very successful. I, Arun Chadha, Senior General Manager, on behalf of Intas Pharmaceutical, would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence in the last 1 year. It's audience like you that make the presentation awesome. Thank you very much for your unwavering attention throughout these presentations. First of all, I would like to thank our honorable course director, Dr. Lakshmi Narasimhan sir, and Dr. Sudhir Shah sir for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DNB students. And I would like to thank to our young neurologist, Dr. Jay Krishnan, for presenting the excellent and unique case. Further to this, I would like to thank the entire Stanley Medical College, Chennai faculty, Dr. Satish Kumar sir, Dr. Somani ma'am for case discussion and differential and final diagnosis. Further to this, I thank to Dr. Viveka Sarvanan sir to provide the important learning points and proceedings of this unique case. Thanks to Dr. Mugandan sir, the HOD Neurology Department, Stanley Medical College, Chennai, has given the excellent expertment for such a unique case with a fabulous presentation. The entire presentation will be extremely helpful and informative to all the participants. Once again, thank you for gracious presence, and it's being a pleasure being with all of you today. Thank you for your patience. I wish you all a very good night now, with a promise that next session on 30th July 2021, we'll meet again with yet another most awaited next session of Secrets of Neurology. Till then, stay safe, stay home. Thank you. Thank you very much, sir.
Thank you, sir. Thank you for the opportunity.
Thank you.
Thank you. Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you.